Awesome. Thank you. I'm glad everybody was able to join us tonight to talk about hyperthyroidism, one of my favorites. And so we'll get into it. Um, I usually like to start off with a little bit of history about where we've come from with our diseases. And so hyperthyroidism is kind of one of the more modern diseases that we have dealt with, thanks to the kind of godfather of thyroid disease, Mark Peterson out of New York City, who first diagnosed this condition as a wasting disease of cats at the Animal Medical Center in New York in 1978. Within a year, he was able to get 5 cases that he presented at the ACVIM forum on this wasting disease. It was ultimately first published in JAVMA in 1980, 10 cases out of Angel Memorial. And then he followed up with a relatively large case series of 131 cases in 1983. And since then, this has become a really common disease process we recognize and deal with in veterinary medicine with a modern prevalence of around 10%. And considering there's about 80 million owned cats in the United States, it's a relatively common thing for us to see walk through our doors as practitioners. Just as a reminder about hyperthyroidism, this is typically a disease that is going to be prevalent in older cats. About 95% of cats are going to be greater than 8 years of age, with the main age at diagnosis of around 13 years. And so while it can happen in animals less than 8, again, any sick cat over the age of 8, it is reasonable to screen for hyperthyroidism. In most cats, this tends to be a bilateral disease process involving both thyroid glands. However, we know that unilateral adenomas can occur, as well as ectopic thyroid tissue outside of the normal location that we would expect. Most cats are going to end up having adenomatous hyperplasia, so a non-neoplastic change impacting both thyroid glands. And so this picture kind of at the bottom of y'all's screen right now is just showing you kind of a normal thyroid gland and a hypertrophied gland that's impacted by adenomatous hyperplasia. Ectopic thyroid tissue is, I feel like, something that we don't talk about a lot, but I think it's worth mentioning because our patients can have thyroid tissue anywhere between the base of their tongue and the base of their heart. And so this may be one of the reasons why you've heard people like me say that we can't really exclude hyperthyroidism due to lack of palpation of a thyroid goiter, because if the ectopic thyroid tissue becomes hyperfunctional, and if it's primarily intrathoracic, we may not actually feel anything external to the patient in their cervical palpation or looking for a thyroid slip. This also becomes important whenever we start talking about diagnosis and treatment of thyroid disease, but just be aware that we have a potential for this disease process to involve not just the location and the midline of the neck. This is something I usually kind of go through with clients in talking about this disease. I usually kind of remind them that thyroid hormone impacts basically every cell in the body, and kind of its main role is to regulate our metabolism. And so I usually tell people that if in a normal patient and in health, that it should be kind of this smoldering fire that generates kind of our heat and keeps us warm. And then obviously in disease states, dogs, we tend to think more about dousing our fire with water and kind of extinguishing that metabolism. Whereas in cats, it's kind of like throwing gasoline on that smoldering fire and having a raging fire as a result of that. And so that kind of helps clients start putting into mind kind of what we would expect as far as ramping up the dial on their metabolism and kind of why we see some of the clinical signs that we see with this disease process. So I put a couple of pictures up here of some different common presenting signs. Obviously, the comparison picture up here of pre and post development of this disease process kind of shows you probably an average American cat who tends to be a little bit chubby and probably a little bit sedentary. And then after the development of this disease process, we can appreciate that it definitely looks like a more raggedy old cat that is skinnier than we would expect, and probably just looks older than what its true age is. Weight loss tends to be one of the most common presenting complaints. And one of the nice things about this is that it oftentimes is going to happen in conjunction with an increased appetite. We like seeing those two things together because the list of differentials for those is a lot shorter than just looking at weight loss or increased appetite separately. Probably one of the saddest clinical signs that can be manifested is some of the behavior changes that cats can develop with hyperthyroidism. Obviously, hyperactivity or kind of being more restless can be common. However, some behavior changes like becoming more angry or kind of more likely to lash out at the client can be possible. And so again, that's one that I don't like seeing because I don't like clients having to deal with a grumpy cat at home. PUPD can occur. It's not as common as weight loss and ravenous appetite, but it is a potential possibility. But by far, kind of the weight loss and ravenous appetite tend to be most common. I wanted to mention this because a lot of people may not have heard of this sign, but there is a form of hyperthyroidism that we call apathetic hyperthyroidism. It's not common, so about 6% or less of cats will present with this. But the reason why it's important to keep in your mind is because basically it's the exact opposite of everything we just talked about. And if anything, these cats tend to look more like hypothyroid cats than they do hyperthyroid cats. And so they may manifest this disease as being anorexic or gaining weight or being more lethargic at home as opposed to being kind of more excitable or restless. And so again, I think anytime you have an older, sick cat, even if it's not showing the classic signs, I think it's still reasonable because of this condition to screen them for this disease process. Probably one of the most severe presentations of hyperthyroidism is going to be hypertensive related end organ injury, which is oftentimes going to manifest within the eyes of cats. Clients may oftentimes appreciate kind of the cat going acutely blind, and then some astute owners may appreciate kind of visual changes to the cat's eyes, and so that they may notice big dilated eyes that have something hanging in the back, which is the retina, or hyphema and kind of the red discoloration. And occasionally with really severe hypertension, we can also get acute CNS signs like seizures or collapse. And so just be aware that those usually are going to present more emergently. And again, hyperthyroidism can be a common cause of hypertension in those cases. Physical exam kind of mimics what we would expect from the clinical signs and the increased impact on metabolism. So oftentimes these cats are going to look unkempt, and they may have areas of alopecia, not from the disease itself, but oftentimes that's going to be from some of these obsessive behaviors that they'll develop and start to kind of overgroom themselves and cause the alopecia itself. As we would expect, a lot of these cats are going to have a low body condition score, mostly characterized by a low muscle condition score. And as part of any feline exam, I think getting a thyroid palpation is important. And so the bottom picture here is demonstrating kind of the thyroid slip assessment to make sure that we don't palpate any goiters that could be an early indicator that something's going on with the thyroid gland. I'm sure we all know that cardiac abnormalities can be really common in these patients as a result of the thyroid hormone sensitizing the heart and cardiac myocytes to catecholamines. And so these guys may be tachycardic, especially whenever they're in the hospital seeing us and being examined. They can have murmurs and gallop rhythms, so the extra heart sound associated with this process. Kind of think about them as kind of a phenotype of hypertrophic cardiomyopathy. We'll also talk about this in a second, but oftentimes these cats will also have evidence of intestinal thickening as a result of the impact of thyroid hormone excess on the GI tract. And so it's not uncommon in these skinny cats to also palpate ropey intestines, which again may add some other differentials on our list that we may need to look into while we're working up these cats for hyperthyroidism. One thing I wanted to mention about the thyroid slip is that we just need to remember that as these glands enlarge, it is very common for them to start sinking down the neck. And so when we're positioning these cats to do a thyroid palpation, it's always important that we start kind of at the top of the cat's larynx and palpate that with your fingers running down either side of the trachea, all the way down to the thoracic inlet, because really big goiters can sometimes sit really low in the neck that you may miss if you're not going all the way down to the thoracic inlet. And so again, the bigger the goiter, the more likely it is to migrate somewhere down the neck. Obviously, if it's ectopic thyroid tissue, it's intrathoracic, you may not palpate any abnormalities during your thyroid palpation exam. Oftentimes, because these cats are presenting to us with concerning clinical signs, I think a minimum database is what most people will do to start. By far, the most common abnormality with hyperthyroidism is going to be elevation of the liver enzymes, in particular ALT elevations. However, you can have primarily ALK phos or both liver enzymes elevated. Azotemia can be present in about 10 to 20%. These are usually older cats, and so it makes sense that they will have some level of underlying renal disease. And we'll talk about some other impacts that hyperthyroidism can have on renal function. And then because thyroid hormone has a permissive effect on the bone marrow, it can stimulate erythropoiesis. And so therefore these cats could get an erythrocytosis that could be in combination with some dehydration associated with kidney disease as well. Nothing really in particular on the urinalysis that's helpful, depending on if they're PUPD or not, depending on if they're hypertensive or not. That may impact things like USG or their proteinuria. I think one good thing that's always a good habit to get into is screening cats for hypertension, especially if we have hyperthyroidism on our differential list, just because it could impact some of the decisions we make regarding treatment, just so that we don't perpetuate other organ dysfunction in the process of working these cats up or treating them for their disease process. So a couple of considerations that we need to have going along this workup is I get a lot of questions from vets of, I want to send you this case that's hyperthyroid, but I'm worried that it has really bad hepatopathy that would prevent you from being able to do anything about it. It can be solely related to hyperthyroidism. I think the highest I've ever seen has been about 915 ALT, all just related to the hyperthyroid disease process. We don't exactly know why this happens. If you go in there and biopsy most of these cats' livers, there's usually no pathology that suggests why the ALT or ALK phos would be elevated in these patients. And so as a general rule, we don't delay therapy in cats with hepatopathies that we've only found hyperthyroidism as a potential cause for those guys. Oftentimes we may be doing, other diagnostics like abdominal ultrasounds to look at other abnormalities that we found on exam or lab work. And ultimately those tend to be normal imaging findings on the liver and just straightforward hyperthyroid cats. The other things to keep in mind are the cardiac changes. And like I mentioned before, these cats oftentimes will develop an HCM phenotype. As a general rule of thumb, I don't think it's ever wrong to echo a cat that has a murmur or auscultable abnormalities in the chest. But I think oftentimes if you refer them for an echo, it's going to say it could be HCM or it could be untreated hyperthyroidism or hypertension. And so treat those things if it's there and then re-echo them after the disease is taken out of the picture. And so for me, I feel like chest radiographs are probably the better way to screen these cats for cardiac disease if I auscult an abnormality, mainly to make sure that the cat doesn't look like it's at imminent risk of going into heart failure or that doesn't have a giant heart. And as long as things look okay and they don't look like their vessels are plump and they're at risk of going into failure, that I would feel comfortable treating that cat and then reassessing the cardiac abnormalities post-control, and then referring for an echo if the cardiac abnormalities persist in the face of a normal thyroid panel. The final thing that we have some confusion about sometimes are the intestinal changes that can happen with hyperthyroidism. Thyroid disease does cause increased motility of the gut, which is going to cause some hypertrophy of the muscle. It also causes lymphocytic infiltration into the mucosa of the gut. And so it will mimic IBD or small cell lymphoma on things like abdominal palpation with that ropey intestine that we talked about. And so I think just be cautious if you're ultrasounding a hyperthyroid cat and they have intestinal thickening, because that could just be a consequence of the hyperthyroidism. And definitely before I would jump to biopsying a cat's intestines based on imaging, I would want to screen for hyperthyroidism to ensure that it's not just a result of this. Because as you can imagine, sending a cat for endoscopy to a specialist and then they diagnose hyperthyroidism can be a unfortunate situation to be put in. And so again, screen cats for thyroid disease if they're sick or ill, because it can mimic a lot of other disease processes. I'm sure we've all heard about hyperthyroidism masking renal disease. It's interesting because thyroid hormone in excess will increase the GFR. That's how it reduces the serum creatinine usually. But I think the thing to keep in mind is that this increase in GFR is actually a bad thing. And that ultimately, if left untreated, it will perpetuate renal injury, and these cats will have negative outcomes associated with renal dysfunction, as opposed to cats who end up getting treated. I think the other thing to keep in mind with renal disease is that these cats may be poorly muscled, and so their creatinine may be actually overestimating their degree of renal function. So sometimes it may be helpful in these cats to consider running an SDMA, especially if it's a cat that you've been trending SDMAs over time. it may be useful to get a better reflection of what their true renal function is going into treatment. And again, we usually follow the Iris Kidney guidelines, and so they're available online for free. I oftentimes will send clients there as well to kind of educate themselves about some of these things that we'll talk about. They have great resources for both veterinarians and for clients. And so kind of the reasons why hyperthyroidism is bad for the kidneys is because of these two highlighted boxes on this graph. And so increased thyroid hormone will lead to RAS activation and increased blood volume, which are going to increase some pressures across the kidney. And we'll talk about that in a second, that are going to ultimately be what damages the kidney long term. And so what does this look like mechanistically? So if this is our nephron with blood coming in and going out, the main driver of our GFR is going to be dictated by this glomerular hydrostatic pressure. And in health, kind of think about this as being like a water hose supplying blood to the kidney to get filtered and make urine. And hyperthyroidism, as a result, we're artificially increasing this capillary hydrostatic pressure by RAS activation and blood volume expansion. I mean, while it sounds good that we're increasing GFR, it's kind of like turning that water hose into a pressure washer. And so that across the glomerular capillaries is going to induce injury, induce proteinuria, is going to induce and speed chronic renal disease progression. And so this is one of the reasons why it is masking renal disease, but that doesn't mean the renal disease isn't there. It means that it's just not being reflected as accurately as it should be on your chemistry results. And so we still need to treat this disease in order to save renal function long term. So thyroid testing, we'll kind of go through this. This is kind of a schematic for what we would expect in health. And so remember that our hypothalamus is going to be directing things with thyroid releasing hormone. That will go down to our anterior pituitary gland, where thyroid stimulating hormone, or TSH, is produced, and then will circulate to the thyroid glands. And it's kind of like the foreman of the warehouse of everything that's involved in uptaking iodide to the formation and release of thyroid hormone from the glands. T4 is the major product that comes out of the thyroid gland itself. And so it circulates in both protein-bound and free forms. And then usually at the level of the tissues, it will get converted into T3, and that's usually the more biologically active form of thyroid hormone. As with any good endocrine system, we should have a nice negative feedback loop that as thyroid hormone levels rise in the bloodstream, it shuts down the hormones that are going to be directing more hormone to be produced. And so most endocrine diseases are then going to be dysfunction of this normal process. And so if we have a hyperthyroid cat that, say, develops adenomatous hyperplasia, we're going to have overactive thyroid tissue that's not really responsive to our normal feedback mechanisms. So as a result, we'll have increasing levels of total T4 and free T4 in circulation, but we're going to be shutting off both our TRH and TSH production. And so in these cats, ideally, we would be able to document low or non-detectable TSH concentrations to confirm that this cat was truly hypothyroid, or hyperthyroid, excuse me. So we have several testing options, and this is one of the reasons I was really excited when I was asked to do this talk, is because historically, I'm sure everybody has probably used Michigan State, who has a wonderful diagnostic lab and is kind of the gold standard diagnostic lab for doing a lot of thyroid testing. They're the ones that can quantify thyroid antibodies and things like that, and so it's a very useful lab to have access to in the States. IDEXX and Antec also have panels that we can submit, as well as other reference labs across the country. Generally, from these labs, we can get total T4 concentrations. Free T4, usually if we're running a free T4, it's going to be by equilibrium dialysis, so that it removes any interference from things like circulating antibodies. And then the TSH assays that are available are going to be canine assays. And so there can be some pluses and minuses for that in use in cats. However, historically, it's been the only option we've had, and have had to use the canine TSH assay for our feline patients. Depending on where you're practicing, you may have access to either a large lab, or at most teaching hospitals like Texas A&M, we usually have big analyzers that have endocrine processing functions. So again, total T4 and canine TSH are usually what the Emulite is going to run. We have a couple of benchtop in clinic assays that have come out. So there's the IDEX Catalyst that only is running a canine total T4 at the moment. And then what I'm excited about is the Truforma by Zomedica, because not only does it have total T4 options, but it also has a feline optimized TSH. And we'll talk about what that means here in a second. But the nice thing about this is that, again, it's benchtop in your practice. We have one downstairs right now, and we use it almost on a daily basis. And so it can be really useful to not have long turnaround times to get answers for patients. So if we're doing a total T4 concentration, this is usually the only test we need in about 90% of cases in order to confirm the diagnosis of hyperthyroidism. And there really isn't another disease process that's going to artificially increase the total T4 concentration. And so if we document this, most likely that cat, especially if they're showing appropriate clinical signs, is going to be hyperthyroid. Now remember that this is a test that assesses all T4 in circulation, so both free T4 and protein-bound T4, which protein-bound is usually the larger component of the two. I usually recommend to our students that whenever they get out into practice, that we should be screening cats probably at least yearly, starting at around the age of 8, or anytime a cat is sick, it would be reasonable to screen them for this with a total T4. We have questions sometimes about, I think this cat could be hyperthyroid, but my total T4 is within the reference range. I put an example up here in an example reference range. Again, the lab you use may have different values that they use for cutoffs. But this cat would technically be in the high and normal range for its T4 concentration based on this lab's reference. And so I think differentials for this would be, this could be a normal cat who just happens to have a high normal total T4. This could be a hyperthyroid geriatric cat. Cats in general tend to mildly reduce their T4 concentrations over time as they age. And so if they were mildly hyperthyroid, that would normally be 4.5, and potentially age could suppress that into a normal healthy cat reference range. And then the other thing is, we usually talk about euthyroid 6 suppression with dogs and hypothyroidism, but remember that it can happen with cats too. And so if this cat was sick with a comorbidity or was severely stressed out, being chased around the house and driven to your clinic and being examined, then we could have some suppression of mild cases into the high end of the reference range. I think the biggest thing is remember that having an understanding about the patient's status, is it showing clinical signs, does it have consistent physical exam findings or biochemical changes, usually will allow you to help differentiate these. Does it have a palpable thyroid slip, things like that. And so the more boxes you check under this cat looks like it's hyperthyroid, then obviously the more likely you would be thinking that this could be a euthyroid 6 suppression of the value into the high normal reference range. If you have a case like this and you're suspicious that it is a euthyroid 6 cat, you can get confirmation of this by running a free T4. Usually if you're going to do it, you want to run it by equilibrium dialysis and a TSH concentration. And as we would expect, the free T4 should also be above reference range, and the TSH should be low or below the limit of detection in overtly hyperthyroid cats. And so again, look at the patient and then decide if you need to do confirmatory testing to exclude euthyroid 6 suppression. We get this question a lot too. If we know that total T4 is not the perfect test, why don't we just use free T4 to screen cats? The problem with this method is that the free T4 concentration can be elevated in some cats who do not have thyroid disease. So they're otherwise healthy, but they have usually mildly elevated free T4 concentrations. And so the risk of monitoring cats with a free T4 is that you could get a false positive diagnosis that the cat's truly not hyperthyroid. And so in general, we don't recommend screening cats with a free T4 alone. If I'm ever running a free T4, it's going to always be in combination with at least a total T4, if not a total T4 and a TSH concentration. So this would be kind of an example of what this looks like, that we have a mid-range normal total T4. We have a free T4 that's 10 points above the reference range, and then a TSH that's in the middle of the reference range for it. And so there's a lot of clues that this cat isn't hyperthyroid. It'd have to be pretty sick to suppress its total T4 into the middle of the reference range. And TSH is usually kind of the most sensitive marker of thyroid hormone status as perceived by the body. And the fact that it's not suppressed would also argue against this cat being hyperthyroid. And so most likely this is a cat who is euthyroid. And you should be getting some clues that this may be a false positive diagnosis with a free T4 by just looking at the patient or signs or labs. Where we run into this being an issue is people who are doing free T4 screenings in cats as part of their like annual geriatric exams. And so again, it probably is best to replace that with a total T4 for screening purposes and not rely on the free T4 alone. So what about issues with TSH? So historically, the TSH assays have always been focused on using canine antibodies and usually are going to be most appropriate for screening for hypothyroidism. And so it's meant to detect really high concentrations of TSH that we would associate with dogs being hypothyroid. And so it's not an ideal assay historically for detecting low concentrations that we were trying to find in hyperthyroid patients. Additionally, the canine TSH assay can either fail to detect TSH of all cats, or you'll get a false negative, not detectable result because the cat's TSH is actually below the limit of detection for the canine TSH assay. And so this would be an example of a cat who has a normal total T4 and free T4 and a non-detectable TSH concentration using the canine assay. And so again, we would ask ourselves, is the TSH truly not detectable, or could this be an assay-related issue? Is TSH actually present in this cat, but it's just below the limit of detection? Or is this one of the cats that the TSH assay just didn't cross-react with their hormone and therefore it didn't pick it up? So we, again, don't usually use this as a sole test to screen cats. And so things have changed a little bit now because we actually have a TSH test that is targeted specifically to screening cats for hyperthyroidism. And so this is a similar assay as to what has been used historically. However, Zomedica was able to generate this test with a much lower limit of detection. And so it's going to be optimized for cats to be able to screen for low TSH that we would associate with hyperthyroidism. And kind of looking at some of the assays in comparison of this feline optimized test to canine TSH assays historically, we have much improved sensitivity and specificity, and the positive predictive value is greatly higher than what it would be for using the historic canine TSH assays. And so this is a really, really good option for us to have in veterinary medicine, especially if you are seeing a lot of feline patients. And again, the nice thing about this is it's a benchtop test. It takes about 15 minutes to get the results back, and you have your TSH concentration in practice. So again, like I said, we use ours relatively routinely, but we also see a lot of hyperthyroid cats come through here. This is just what the cartridges look like that go into the machine for the Truforma. It's a better tool in general for thyroid screening. We usually are going to use this in combination with total T4. It's also useful because usually TSH suppression is going to be one of the first indicators that hyperthyroidism is developing. And so these cats may have normal total T4 concentrations, but low TSH, which may be their first indicator that the disease is developing. We'll also talk about some changes in monitoring that have occurred over the past several years. And now TSH is a very common recommendation for monitoring both methimazole or post I-131 treated cats long-term. And so this would be an ideal assay to be able to have to screen those cats while monitoring their therapy. Again, for monitoring hypothyroidism in cats, again, the sensitivity and positive predictive value are much higher than the canine assay, as well as just using a total T4 alone. And we'll talk about why that is because of some iatrogenic or subclinical hypothyroidism that can occur with the treatment modalities that we use. So TSH screening in thyroid disease. So again, remember that low TSH may suggest early hyperthyroidism. Sometimes this may not be as helpful if you have just detected it on a one-off spot check, because if you have a normal total T4 and a low TSH, if you've used the historic canine assay, you could have the same issues that we've already talked about. Whereas if you use the feline optimized one, chances are if it's below that limit of detection that you have suppression of TSH, that's more likely to be developing hyperthyroidism. Where this can really be useful is if TSH has been something that's been serially monitored in these cats as part of their yearly screening, and now all of a sudden a cat who previously had a detectable TSH concentration has a non-detectable concentration. then that would definitely fit with this being an early change that the cat is likely to develop fulminant disease within the next 6 to 12 months. We don't necessarily start treating at that point, but I might change my recommendation of, as opposed to coming back in a year for your next screening, maybe let's plan on 6 months and or earlier if the cat shows any of these clinical signs at home. So again, it may allow us to be more rapid about the detection, diagnosis, and institution of therapy in these cats by using it. So a couple of examples of this, and so this would be the kind of situation I was just talking about, where we're screening this cat with a thyroid panel every year. And so last year, the cat looked good and had a detectable TSH concentration. And then it came in for the next year, and things still looked okay as far as being within reference, but now we have a non-detectable TSH concentration. And so we went from normal to now most likely this being an early hyperthyroidism patient. And so again, it does require that you have some serial monitoring to be able to do. And then finally, we get to talk about treatment. So we'll go through a lot of the therapies that we use commonly. The one we're not really going to talk about today is thyroidectomy. We don't tend to use this as a treatment modality anymore. Technically, radioactive iodine has replaced thyroidectomy in most situations as the definitive treatment for this disease process. But we'll go through the other three. The first one we'll talk about is the Hills YD diet, which remember is an iodide restricted diet. So it's basically Hills JD with the iodine taken out. And so most diets out there are going to be about 0.46 parts per million, whereas YD is about 0.2 parts per million or less. So this is schematic kind of showing you the bloodstream on one side, and the little orange slices are our iodine, and then the pink balls are our thyroid stimulating hormone. And thyroid stimulating hormone binding to its receptor on the surface of the thyrocyte is going to activate the sodium iodide symporter, which is going to move both sodium and iodide into the cell. That iodide will get transported across the cell into the border between the cell and the colloid. And then thyroid peroxidase will move that into the colloid and then use the scaffolding of thyroglobulin to kind of build T4 and T3 from. And so the idea with this is by restricting that iodine, we're limiting the building blocks for these cats to be able to build thyroid hormone, and therefore they can't produce as much, and thereby treats their hyperthyroidism. A couple of downsides to Hills YD diet is that it really is the only thing the cat can eat, because most other treats, foods, or if the cat's an indoor-outdoor cat and goes and kills a mouse, eats the mouse, that's going to be a big blast of iodine that could then cause relapse of clinical signs of the hyperthyroidism. And so keeping that in mind, that palatability may be an issue. And so sometimes, slow transition onto the new diet can help with acceptance of the diet. But these are usually going to be best used in single cat households where they can control the environment that the cat is exposed to. It is labeled to be safe for non-hyperthyroid cats. It may just be an expensive way to feed a multi-cat household. And so usually I'm pushing this more as an option for indoor-only single family or single cat households. If they have multiple cats, then as long as they can separate them and kind of make sure that we don't have access to other food sources, that would be ideal. With YD, it is an effective diet to control hyperthyroidism. Most cats usually are controlled within 4 to 8 weeks. And so I think the thing to kind of keep in mind with this is that if you have a cat who's having really severe clinical signs or has really severe sequela of hyperthyroidism, like hypertension and retinal injury or CNS signs, we may not have a month to 2 months to wait for the thyroid disease to become controlled. But as long as the cat's otherwise stable, YD would be a reasonable treatment option. In general, we tend to think that the higher the T4, the longer it's going to take to fully control. However, most animals are still controlled within the first 2 months. A few cats in some of the original studies took up to 6 months to fully normalize their thyroid hormone concentrations. But again, those are more of the exception than the rule. The one thing that you want to try to avoid if you are using this as a therapy is that you don't want to use it in combination with methimazole, because it greatly increases the risk of hypothyroidism developing in those cats. It is fine to stop the diet and switch to methimazole, but you want to not use them in combination. So methimazole is what most people are going to end up using in practice. It's the most prescribed therapy for hyperthyroidism. It is a blocker of thyroid peroxidase, again, which is the enzyme that's kind of the workhorse of thyroid hormone production. And so it's going to be the one that's moving iodide into the colloid. It's going to be the one building the T4 and T3 along the thyroglobulin molecule. And so by blocking that enzyme, we are basically stopping the production of thyroid hormone in these patients. I think the one thing to keep in mind with methimazole is that it's not doing anything to destroy tissue. And so for diseases like adenomatous hyperplasia or an adenoma, there is potential that those masses could enlarge over time as continued hyperplasia occurs or as continued non-neoplastic growth occurs. And so just keep in mind that that will potentially impact some treatment factors that we have to consider while troubleshooting some methimazole issues here in a second. In general, most people are going to start at about 1.25 to 2.5 milligrams per cat by mouth twice a day. And then generally, we will adjust our dose every 2 weeks with oral therapy until the total T4 and TSH are controlled. We'll talk about what treatment targets we're shooting for here in a second. And so just as an example, if we've started the cat on 1.25 milligrams twice a day, and we get them back in for a recheck and we're not happy with our control, then we would kind of stepwise usually increase their treatment. And so we would go to 2.5 in the morning and 1.5 in the evening. And then again, give them another couple of weeks to get them back in and recheck and keep increasing the dose until we gain control of the disease. There are some pretty significant adverse drug reactions that can occur with this therapy. And so it's definitely worth having this conversation with clients. Probably the most common one that we see is going to be a direct GI upset. That is a true drug reaction on the mucosa of the upper GI tract that will cause usually vomiting or diarrhea, kind of usually within 30 minutes to an hour or two after dosing. And it's usually going to be a repeatable thing that they'll call you and say, I've given 3 doses and the cat's vomited every time I've given it. You know, what's going on? And we know that that's usually going to be the direct GI upset. We can induce iatrogenic hypothyroidism, and it's shockingly more common than you would think. Some of the sad reactions that can occur are facial excoriations. So these cats develop a really intense facial pruritus, and they will literally claw their faces off. We've seen some really sad cases where therapy was continued in the face of scabs and scratches kind of being apparent on the cat's face, and to the point where the cat literally came in with raw face. And so be aware that that is a really bad reaction that requires immediate discontinuation of the therapy. Hepatotoxicity can occur, as well as blood dyscrasias. And so these are one of the reasons why we will recommend some blood work monitoring during the initial phases of methimazole treatment. In particular, thrombocytopenia and neutropenia tend to be the most common of the blood dyscrasias that can occur. And then finally, rarely, the cats can develop an acquired myasthenia gravis, which is oftentimes going to manifest as the cat developing a megaesophagus and kind of having regurg type signs at home. Luckily, this is a reversible process. And so by stopping the drug, usually the megaesophagus will resolve on its own and doesn't require any other long-term therapies. But be aware that if you have a cat that's on this, starts regurging, that myasthenia gravis is not the most intuitive differential to have on your list. But it has been reported now in multiple cats. And so kind of how do we respond whenever we encounter these adverse drug responses? Really, the only one that responds to a formulation change is going to be direct GI upset. So I started this cat on oral medication. It's vomiting every time it gets dosed. It's not a methimazole issue in the body. It's a oral methimazole issue on the GI tract. And so it would be appropriate to switch that cat to a transdermal formulation. Or if methimazole is not going to work, try Hills YD or refer for I-131. But this is kind of the best situation to consider transdermal if they don't tolerate oral. If the cats develop hypothyroidism, then typically our response with methimazole is to either reduce our dose, or depending on how severe the hypothyroidism is, we may actually give them a drug holiday and discontinue the medication before restarting at a lower dose. They can have two forms of this, and we'll go into this in more detail here in a little bit, but oftentimes these cats, if they develop hypothyroidism, are not going to show clinical signs. And if you're only monitoring their T4 is often normal. And this is why the recommendations have changed to start monitoring TSH, is because subclinical hypothyroidism is going to be manifested usually by a significantly elevated TSH concentration. And that would warrant a treatment change if found. If cats are clinical for hypothyroidism, which again is luckily rare, they usually will have a low T4 and high TSH and consistent clinical signs like we would expect with a hypothyroid dog. And some of these cases may require temporary drug discontinuation and or supplementation of levothyroxine until the cat becomes non-clinical for the disease. Usually after stopping the methimazole, it will recover over time. So it's not typically a permanent change that would require lifelong supplementation. All other drug reactions, the hepatotoxicities, the blood dyscrasias, are a methimazole drug reaction in the body. So it doesn't matter how methimazole gets in the body. If it gets in the body, they will keep having these negative responses. And so if you notice anything off, then it is we must stop methimazole and switch to a different treatment modality. We sometimes have seen some of these cats that have developed facial pruritus on oral and they got switched to transdermal. And again, that's not a way to stop it. Those cats will continue having that side effect. So transdermal methimazole is a effective therapy, and it can be used as a first-line therapy in cats that are either fractious or the clients can't pill well at home, or for those cats like we talked about that have GI upset on oral formulations. A couple of differences to consider with transdermal as compared to oral. Usually transdermal are going to require higher doses than what you would have used with oral medications. And so in general, most cats often end up somewhere between 2.5 to 5 milligrams BID for their methimazole dose, whereas transdermal is often going to be 5 milligrams BID or higher to control their disease process. I still don't start any higher than 2 mg per cat twice a day. And again, I just expect that I'm more likely to have to dose increase with that as compared to oral. And then additionally, it does take a little bit longer for transdermal to fully control the disease process. And that's going to impact my monitoring recommendations. And so if I'm starting oral, I'll probably get them in at least every 2 weeks to start monitoring and adjusting my dose. Whereas with transdermal, I'll probably push it out to 3 to 4 weeks to make sure there's plenty of time for the absorption and effect to achieve a consistent response so that I'm monitoring an appropriate thyroid response to the transdermal medication. But again, it's as effective as oral, but there are a little bit of differences between how we would approach monitoring therapy. So methimazole monitoring, currently the recommendation is, in any hyperthyroid cat treated with methimazole, is that we should be monitoring them with a total T4 concentration and a TSH concentration. And again, this would be included in our 2-week rechecks for oral or 3 to 4 week rechecks for transdermal patients. And then because of the blood dyscrasias and hepatotoxicity, it's generally recommended that at least for the first month or two, you do intermittent CBC and chemistry checks to make sure that they don't develop blood dyscrasias or hepatotoxicity. If they tolerate it for the first couple of months, chances are they're not going to develop this as a late stage response. And so it's not something that you have to keep monitoring over time. The reason why we recommend monitoring TSH is one of my former students from Georgia, Charlie Aldridge, wrote this paper whenever he was at Auburn, again, looking at the effect of the thyroid panel on cats receiving methimazole. And in these cats, there was a 33% rate of subclinical hypothyroidism where these cats developed an elevated TSH with a normal total T4 concentration. And the reason why this is important is because of the cats that had a high TSH, almost 40% of them also developed a new or progressive azotemia. We'll talk about why that's important, but that is going to dictate treatment changes that we would need to do. And so I think if we're going to safely monitor these patients, then total T4 and TSH is the best way to approach monitoring of these medications. Our treatment goal for T4 is for it to kind of be in the mid to low range. There are guidelines out there, including the AHA endocrine guidelines and the AAFP feline guidelines for hyperthyroidism that provide specific treatment targets. But for me, as long as they're in the mid-ish range of the reference interval and not showing clinical signs, I'm happy. So I don't have to necessarily hit a specific number for me to consider it a success. After you've controlled the disease process, if you're on oral medication and the clients are having a hard time medicating the cat, it is okay to try to reduce it into a once daily dose. The reason why we split it Q12 is to try to minimize some of the side effects, especially the GI toxicity associated with methimazole. And so if they've tolerated it over time, let's say they end up on 2.5 milligrams twice a day, you can try to combine those doses and just give them 5 milligrams once a day moving forward. And if they tolerated it that long, then most likely you're going to tolerate the once daily dose. A couple of troubleshooting issues. If you don't see a response with methimazole and you've progressively increased your dose of methimazole and you're kind of reaching ranges of 10 milligrams or more twice a day, some considerations or red flags that need to go off in your head are that could this be a carcinoma or could this cat have ectopic thyroid tissue? And both of these tend to be more treatment responsive, or excuse me, treatment resistant to methimazole. And so if you have any questions about tolerance or resistance, then those would be my biggest concerns. And I would probably consider referring that cat for thyroid scintigraphy to assess for carcinoma or ectopic thyroid tissue. But I think anytime a cat is on 15 or 20 milligrams of methimazole, starting making me a little bit nervous that it's not going to be the thing to fix the cat's disease process. I think the other thing to keep in mind is that if you've diagnosed a cat and they've been on methimazole for years, because methimazole is not destroying tissue, it will continue to grow, and occasionally it will kind of start to grow enough that it overcomes the ability to control the thyroid hormone production with the dose that previously worked. So if you have cats that have been on it for years and all of a sudden they stop responding, it may just be that they need dose escalation at that point to accommodate for the continued growth of the thyroid goiter. And then finally, radioactive iodine. I'm not going to talk a ton about this, but I'll focus mainly on kind of what most practitioners are going to be involved with as far as screening cats to be referred for I-131, and then a lot of the post-operative or post-procedural monitoring that occurs once they come back to you guys. But just as a reminder, radioactive iodine or I-131 is going to actually destroy the hyperactive thyroid tissue. And if done well, we usually will spare a lot of the suppressed normal tissue that will then wake back up after the hyperactive tissue is gone and start producing normal amounts of thyroid hormone. In the vast majority of cats, this is just a one-time sub-Q injection. On average, isolation times are around 3 to 5 days, depending on the state you're at. There may be different regulations that dictate shorter or longer isolation requirements. But our goal is to try to reduce them or have their radiation levels reduced to a safe level so that they can be around their families at home without concern for contamination of the environment or their clients. In general, cost around this tends to be around $2,200 to $2,500. And there's obviously going to be some regional differences across the nation that may impact cost of this procedure. Success rate is very high. Most animals do fine with one dose and are successful in about 90 to 95% of cases. Treatment failures are usually defined as cats that don't fully respond to one dose and require a second injection of I-131, which is unfortunate, but does occur sometimes. And at some point in the future, anywhere from 6 months to years after the original treatment, it is possible that cats could relapse. If one gland was adenomatous at one point, the other one could become a problem in the future. So we usually prep clients for, especially if they have unilateral disease, that the other gland may become an issue that will require intervention in the future. We used to talk a lot about methimazole trials, and there used to be a big push to try to consider putting cats on methimazole before you would consider referring them for I-131. And the reason why this was usually recommended was to see what level of renal disease was going to be unmasked by taking away the hyperthyroidism. This has kind of fallen out of favor for most facilities that are doing I-131 injections. And for the most part, they're not needed before we would consider treating for I-131. And so I would say don't feel like this is a requirement, especially if you are in Texas and going to send cases to A&M in the new hospital. We don't require this. I think the one situation where it's worth considering would be if you have an untreated hyperthyroid cat who has significant underlying renal disease, because we know that because the hyperthyroidism is making it look better than it is, those cats could be at risk of decompensating with a uremic crisis once the hyperthyroidism is gone. And so usually I would say if your creatinine is greater than 2.5 or 3, then sure, it's not going to hurt anything to do a methimazole trial. And if the cat gets really sick, being on methimazole, then that tells you that they probably wouldn't be a good candidate for I-131. But for most cats that are either IRA stage 1 or stage 2, or even high stage 2, I wouldn't necessarily require it before I would treat the cat. A couple of pre-referral considerations. Ideally, we want these cats to be as systemically stable as possible. And so generally having at least a minimum database, plus or minus any imaging of concerning abnormalities would be ideal to do before I-131. The main reason why we require this is because once the cat gets injected and is radioactive, we have very limited ability to provide a standard of care to that cat in isolation. And so we're limited in what types of handling, medications, or treatments we can offer them in isolation if they get sick. And so we try to do everything possible to make sure that they're going to make it through their 3 to 5 day stay in isolation without having an issue. It is ideal if we can document the high total T4 and an undetectable TSH concentration. We'll talk about why that is here in a second. If they are on methimazole already, if you are just referring them to the facility to get I-131, you do not have to discontinue their methimazole. They can get I-131 the day after they stop methimazole. And the reason why we typically recommend stopping methimazole for 1 to 2 weeks beforehand is because a lot of these facilities are going to do thyroid scintigraphy to characterize the disease process. And so this is a panel kind of showing you 4 different cats with different types of hyperthyroidism. And thyroid scintigraphy can be impacted by patients being on methimazole because it will cause artificial uptake or increased uptake of the isotope into the thyroid gland, and it will make things look worse than they are. So if the cat had unilateral disease that was on methimazole and we did scintigraphy, it could look like it had bilateral disease. And so really it's only a requirement if scintigraphy is going to be done. So it's always good to speak with the facility you're going to refer to kind of see what their protocol is before they treat. I would say most places are doing scintigraphy as a way to not only characterize it, but based on the imaging, we oftentimes will determine doses of I-131 based on the scintigraphy. And so it's a good thing to be aware of. If the animal is on YD, it is important that they stop that before getting I-131, just because the iodine restriction will then reflexively make their thyroid suck up every iodine molecule that it has access to. And if they absorb a lot of that radioactive iodine, it may end up destroying a lot more of the normal tissue than we would like. And so the risk of post-treatment hypothyroidism becomes increased. We don't have great evidence-based of how long to stop YD before treatment, but I would say generally if we can stop it for 2 to 4 weeks beforehand, that usually the animals do fine with treatment. And so kind of this is what we look like in an untreated animal with hyperthyroidism. So the red clouds are nasty hyperfunctional tissue, and then the blue circles are healthy tissue that in an I1 or in a hyperthyroid state, hopefully only the hyperfunctional cells are taking up iodine, and therefore will only take up I-131. The reason why it's a good idea to have a TSH concentration before injecting a cat with I-131 is that it helps confirm that the normal cells are not being stimulated to take up iodine. Because if you remember, TSH binding to its receptor is what turns on that sodium iodide symporter. And so if there's no TSH, that means the healthy cells are not taking up iodine. And so then once we confirm that it's not going to go into the healthy cells, we can give them the I-131, emit the beta radiation that destroys the cells and spares healthy cells that then wake up and can make the T4 again. Post I-131, this is generally where they're going to start coming back to your practices for monitoring. And just like methimazole, the current recommendations are to be monitoring a total T4 and a TSH concentration. And so our normal recheck schedule is oftentimes going to be rechecks at 1 month, 3 month, 6 month, and 12-month post-treatment to make sure that we gain control and maintain control of the disease post-injection. Most animals are controlled within the first month, and full response can take up to 3 to 6 months, and a minority of cats that may be delayed responders. I usually will not retreat a cat any earlier than 3 months unless they have a severely elevated T4 and are severely clinical, and we made no difference in their T4 reduction with the first injection of I-131. But if an animal is kind of mildly hyperthyroid for a month or 2 after treatment, I wouldn't consider them a failure until at least 3 months before I would consider re-injecting them. And then about less than 5%, so it's a very rare complication that these animals will develop clinical hypothyroidism. And those guys generally are going to need levothyroxine supplementation to resolve the clinical signs. It does tend to be temporary, and so usually within 1 to 3 months, they will wake up their normal cells and start producing their own T4 again. For cats, we do things a little bit differently than dogs, and so we usually able to start cats on 0.1 milligram of levothyroxine per day. Give them, a week or two on therapy, and then kind of we'll monitor them to make sure that their TSH concentration normalizes, or that their total T4 comes up into the reference range. So the nice thing about the Truforma, again, is because of these monitoring recommendations that have changed for safely monitoring these cats' therapy, this now kind of would allow us to have a complete recheck assessment done in-house at a turnaround time of 15 minutes per test. And so, again, it can be a really helpful tool for us to get real-time answers for our patients. So subclinical hypothyroidism is one of the issues that has been the reason why we changed some of our recommendations for monitoring. Some people refer to this as iatrogenic hypothyroidism as well. And it does occur in about 30% of treated cats with either I-131 or with methimazole. And again, the way we diagnose this is they have a normal total T4 and a high TSH concentration. So this is an example of a cat that we treated previously, who again, if we were just monitoring a total T4 concentration, we would have said everything looks fine. But now its TSH concentration is significantly elevated. I think the highest TSH we've had has been about 14. And so these cats can have profoundly elevated TSH concentration. So their body is screaming that they need more thyroid hormone. So why do we care about being subclinically hypothyroid? Usually in this process, about 15 to 49% of treated cats will develop some level of azotemia post-treatment. The development of azotemia is much more likely if animals develop hypothyroidism, not just clinical, but subclinical hypothyroidism as well. And a euthyroid cat who develops azotemia, their survival is not going to be any different than a non-azotemic cat. However, if you have made a cat clinically or subclinically hypothyroid and they develop a new or progressive azotemia, their survival is usually significantly less than animals that are hypothyroid that do not develop an azotemia. And so historically, when we've been monitoring cats with just total T4 concentrations, we have likely predisposed them to earlier renal deaths as a result of not recognizing that the high TSH could be what's driving their azotemia development and saying that they're hypothyroid. So what happens if you make a cat hypothyroid with either methimazole or post I-131? In general, if they have no clinical signs and they have no new or progressive azotemia compared to post-treatment, I usually define progressive azotemia as about a 20% or less, or more increase compared to pre-treatment values. Then you can usually just monitor the patient if they have gotten I-131. And usually I would monitor them about monthly. The TSH will oftentimes normalize within 1 to 3 months post-treatment. Again, remember, if they're on methimazole, it's okay to then dose reduce them until the TSH normalizes. If they have a high TSH and they develop a new or progressive azotemia, so again, a 20% increase from pre-treatment values, the recommendation would be post I-131 to supplement these cats with 0.1 milligrams per day of levothyroxine. And we would adjust their levothyroxine dose until their TSH normalizes. We've had several cats now that have come in that have had progressive reduction of their TSH, though it remained elevated, and on their levothyroxine started to get hyperthyroid based on their total T4. And so if you encounter that type of situation, oftentimes we will then ignore the TSH and focus on the T4 and try to maintain that in a high normal range with supplementation. And so we do think there's some residual cats that may not fully normalize their TSH and may get over supplemented with total T4. Again, it's uncommon, but is still likely something you would see in treated cats. And then remember that if they are on methimazole, this would definitely be an indication to dose reduce their methimazole dose until the TSH reduces into the normal range. Oftentimes, if they develop some clinical hypothyroidism, it is a temporary change, and oftentimes will resolve on its own within 6 months, including cats that require supplementation. However, this can be a permanent change following I-131. And so this is a picture of my own cat who was treated at Georgia. years ago and was a sensitive little soul and developed permanent hypothyroidism as a result of his I-131 injection. And so I think it's important to recognize, and it's also important to warn clients about, because oftentimes they're coming to us for I-131 because they can't medicate the cat. And a risk is we could make them permanently hypothyroid that requires lifelong supplementation of levothyroxine. So I try to be upfront with people about that. We try to dose patients conservatively, and so that we don't increase our chances for hypothyroidism post-treatment, but it's always a risk in I-131 treated cats. So what about prognosis? In general, survival tends to be fairly good with treatment. In general, patients that don't have severe underlying renal disease or are not azotemic pre-treatment, as you would expect, tend to do better. And then this top graph is kind of showing you different treatment options of cats treated with I-131 or methimazole. And so you can kind of see that methimazole-only treated cats had a median survival time of about 2 years, whereas I-131 treated cats about 4 years. Sure, while that makes I-131 sound better, I still consider them both effective and equally acceptable treatment options. And so don't feel like that should make you refer every cat for I-131. There are lots of helpful resources out there. And so the AHA endocrine guidelines were released in 2023. And the AFP management for feline hyperthyroidism are also available online for free. And so if y'all have not accessed those, then feel free to get those resources, because they are kind of quick guide references to try to help you with multiple endocrine diseases for the AHA paper, and then for hyperthyroidism specifically for the AFP guidelines. And outside of that, I am happy to take any chat questions that people may have put in.